Well, hello and welcome to another Stuart Soundbites podcast, pre-recorded on this occasion. I hope that you're all well and enjoying the last of the summer weather wherever you are. I'm delighted today to be speaking with Dr. Rodri Philip, OBE. Rodri is a consultant in rheumatology and rehabilitation medicine with a master's in sports injury. He currently works with Pure Sports Medicine in London, Remedy Healthcare, Dorset Orthopedics, and independently in a treatment capacity. He also works within rehab MDTs and assists the court by giving expert evidence in catastrophic injury cases. He's a busy lad, but he's saved a little bit of time for us this afternoon. He's also previously served in the military at, amongst other places, the Defence Medical Rehabilitation Centre, formerly Headley Court, and then latterly Stanford Hall, where his primary role was complex trauma rehabilitation. Rodri's worked with elite army and combined service sports teams, assisting many of his military patients in achieving their sporting ambitions. Now, in our past roles, it's fair to say that I would be stood to attention speaking with Rodri, but he's kindly agreed that I can stand easy for the purpose of this chat, so we can crack on. Well, hi, Rodri. It's good to see you, and thank you again for agreeing to speak with us.
No worries at all.
Rodri, now I've represented a number of clients with life-changing injuries who have service backgrounds, and I've seen the incredible journeys that they make from their injury through their military rehabilitation, through into civvy rehabilitation, and then on into community life. Probably not as many as you've seen, however. I was just wondering though, what do you see are the main differences that exist between military and civilian rehabilitation programs?
I suppose it's worth splitting them up a little bit into military, civilian from a private basis, and civilian from an NHS basis. The main biggest difference has to be the fact that the military essentially is our employer when we're in service, and all of the military medical services are essentially an employer-delivered service. Not surprisingly, if you spend whatever it is, a couple of million quid on getting a fighter pilot trained up, or plenty of thousands of pounds getting an infantryman trained up, there's little point wasting that money if they get injured. So at the more simple end of the spectrum, somebody gets injured doing adventure training or going for a run or things like that, then it makes sense to have a good rehabilitation service aimed at getting them back to full duty as soon as possible. There's no point having people who are non-deployable, which essentially is the ultimate job role for anybody in the military. No point having them non-deployable, and therefore the less time you have them non-deployable, the more individuals you've got to make use of. It also means that at the more catastrophic end of the spectrum, you end up having resources aimed at trying to get people back to work in some capacity, probably slightly more focused than you do get on the NHS side. And ultimately, if patients are unable to get back to military service, there's that moral imperative that if you place people in harm's way and they've got badly injured, whether it be through conflict or training exercise issues or whatever, there's a moral imperative to get them healthy as you can, so that they're at least disadvantaged as possible. And that also then, without being too callous about it, has implications for recruiting. Nobody's going to join a military that basically doesn't make any effort to help people out after they've been injured. So, certainly one of the things that I think the quoted paper from back in 1919, where they said about the importance of having rehabilitation services in the military to ensure that the military maintained their numbers and people didn't become disillusioned and fail to join up. I don't think certainly our motivation was never that callous, but the aim really was to always get people back as good as possible. I think the reality is that then gives you a different funding structure. You have a funding structure aimed at trying to get people as good as they can be. Whereas I think it's fair to say in the NHS, with the limited resources it's got, it's often doing the best it can in the circumstances. And certainly over the last 20, 30, 40 years, rehabilitation services within the NHS have been more focused on brain injury and neurological rehabilitation and amputee work than maybe as much trauma, as much on the trauma side for sort of musculoskeletal things. There are now SEM doctors working in the NHS, which will probably help on that side a little bit. But I think also there's an element whereby you get people fit for discharge rather than necessarily fit for life. And community rehab can be a little bit not quite postcode lottery. I think that's being unfair, but basically can be variable from place to place. And there's certainly, in my experience, different levels of intervention depending on where you often are and what schemes are in place, etc. From the private side, from what I've seen, that varies as well, with different providers able to do different things. Just from my simple experience of medical legal so far, it's evident that the interplay between defendant and claimant lawyers can often have an impact on what rehab you get, unfortunately. And often there's a lot of justifying, which can lead to various rate determining steps that slow up the progress from what we'd ideally want. I think there are some, certainly up at Stamford Hall now, there's a new civilian centre going in, which will hopefully mirror some of the work that the military were doing up there. And maybe that will act as a good benchmark for introducing more trauma services in the further around the UK. I certainly think that's their hope anyway, is to do that.
Yeah, it sounds very interesting. Particularly in relation to Stamford Hall. Just on the claimant and defendant, we see that. You know, it's Stuart, certainly the approach we like to take is one of collaboration with the defendants that we work with. It's often a sensible way forward is to work with the other side. For the benefit of the injured person. It benefits everybody at the end of the day. So hopefully that comes across when you're working with Stuart. One thing, one issue I'm always keen to see develop is the working relationship between the military rehabilitation team and their personal rehabilitation officer, and the civilian case manager and the MDT. Do you have any recommendations for the case managers who will be watching this podcast and the wider MDT members on working with their military counterparts?
Yeah, well, hopefully. I mean, my role within the military, within looking after a complex trauma team, was often very much mirrored that of a case manager in the civilian world. So I had those interactions with the PROs, which I think are personnel recovery officers technically, but basically interacted with them. Now, to be honest, like everything in life, there's good ones and less good ones. I think the reality was that often the thing that needs to be taken into account is those individuals were often coming from a what I'd call big army background, so they weren't medically trained. Often they'd gone through a training process, but essentially came from normal regiments and normal military life. And whilst they will have been involved in the welfare of soldiers throughout their careers, no doubt, in order to get to that point, there were occasional little gaps between where medical elements didn't quite mesh in that totally with the welfare side of things. I think also there is the PROs have a lot of procedures and processes to follow. There's lots of timelines that are built into the schedule. So at so many days, you have to have a review. At so many days, progress has to be seen, etc. And some patients, some individuals will be a little bit more flexible with those. Other people will be a bit more precise with them. And the nature of bad injuries is that it often doesn't conform to exactly what a template ideally wanted it to do. So ultimately, the key to any good relationship is communication. We had a lot of work where we were often working with RFU welfare support people and things like that when patients have been injured in rugby games. And I think the great advantage I found is often they were able to access funding and funding streams faster than we could, and potentially introduce aspects of better welfare support or things like that we were going to find it hard to do as quickly. And so certainly if case managers are coming from an insurance perspective, where there is the potential to unlock funds a little quicker maybe than the military system will allow that, then there's an opportunity to exploit that for the benefit of the patients, which takes the pressure off the military as well as helping the patient as well. So I think if you can get that good communication and that good relationship going at an early stage, understand where you're both coming from, then that has a major benefit down the line in taking advantage of using whichever system is going to help the patient most at that particular time.
Yeah.
I'm not sure whether the PRO or the sort of the welfare service do any sort of education bits where they get a PRO on to have a chat in a similar format to this. But I mean, certainly that'd be useful because I was involved in a bit of the process of setting up that service, almost certainly had was present at some of the meetings where they were deciding how to do things. And I think one of the things from our perspective was always making sure that we had as good a communications as possible. But I also know that occasionally I ran into little roadblocks, which from a medical perspective were frustrating. But I'm sure on the flip side, from a personnel perspective, they were probably quite frustrated with the way the medics were doing things. So, it was little things like that. I suppose one good example would be we were often getting patients, certainly the traumatic injuries, back to their units, more to realize, to be honest, that their life was changed and they were not going to be able to return back to service, but also to catch up with friends and mates and sort of get through that, going back to where you used to be and seeing all those guys in the right context as opposed to in a social event. Some of the PROs felt that was a very negative thing because we were giving people unrealistic expectation of being able to return to military duty. But however positive the patient was about being able to go back, the reality was that when they got back, it very quickly became clear to them that it was going to be, the end of that part of their military career and a switch on. And so psychologically, it was quite helpful, even if it seemed to be a negative experience, if you know what I mean. They failed the return to work, but the return to work psychologically enabled patients to move on better. And we generally saw a switch in their focus then away from possibly some unrealistic goals, reasonable goals, but unrealistic ones, to a more focused, realistic goals on helping them go forward in their future. And I think that's one thing where the more comms you've got and the better working relationship you've got, the better that process is going to go. Because then you're then not sort of fighting against each other to achieve the same outcome, really.
Yeah, absolutely. I mean, I'm just thinking about a case that I've got at the moment where my guy suffered a very nasty brain injury in a road traffic accident, and that's pretty much been it. He's not had an opportunity to go back to see his mates that he used to serve with, and he's a senior non-commissioned officer. He's not had a chance to say goodbye to them. A few of them have popped up, to say hi and catch up, but he hasn't had that closure.
Yeah.
But and as for the communications, 100% with you on that one. What we tend to do is to kind of invite the PROs along to the MDT meetings so they're
Exactly.
fully up to speed, and of course share documents as well, particularly when that military rehab's ongoing. Perhaps the client could be going down to Stanford Hall for a bit of rehab or whatever. So yeah, I fully agree that communication is king there, isn't it?
Yeah, and it's respecting each other's different perspectives, isn't it? Because essentially the PROs are employed by the employer to
Hmm.
manage that process, and ultimately for many of the traumatic patients, that's going to be leaving the service,
Yeah,
and it's doing that in the best way possible, isn't it? Really, and I think at times I must admit I probably got on a medical high horse and probably didn't listen as much to the PROs as I should have done. But in certain circumstances, it was also quite important to make those medical points because so many cases are it's one of the difficulties of complex trauma. Cases are so unique often with so many unique components that it really is hard to have a template that works for all.
yeah,
So, sometimes you have to make exceptions or work outside the rules a little bit.
yeah. Now, in Civvy Street, you're still a consultant in rheumatology and rehabilitation. And in your civvy work, you're often invited into rehab MDTs. When do you think is the best time for a rehab consultant to come in to an MDT? What factors are there to consider, and what difference is it that you can make?
Is always the difficult bit. This is the bit where you sell yourself, isn't it? Really, but um, uh, bottom line is, from my perspective, I think we've got value from the beginning, to be honest. I was chatting with a couple of my therapists today because we were having to put together reasons for why it was necessary for me to be part of the team for a patient going forward. And I believe the defendant solicitor was being a little bit hard over on it, and we were trying to explain the difference. And I think what I see, having done quite a bit of medical legal work now as well, and also reflected on working back in the military, where our MDT was, often 10, 15 people, with the principals generally in the meetings, but definitely a wider team of up to 100 therapists working alongside, was that most of the time what we were doing was hopefully facilitating the therapist to do their absolute best and use the whole gamut of their skills by taking on board a lot of the risk and that oversight to make sure that one issue didn't influence another negatively or cause a compromise. So in a simple example, it would be something when we first had patients starting doing running training after amputations, sorry. Often that is going to involve quite a bit of falling over, because as you start running it's hard to do that without risk. So what we do is we make sure that we've got as little risk as possible, minimize what we can, but also at the other end of the spectrum, you've got to accept that there's going to be some falls and some potential soft tissue injuries and things like that. And it can sometimes be difficult for the therapist to take that risk on themselves. Whereas, sadly, still in this world, if you're a consultant, you're able to take those risks and absorb them, and the organisation overall will accept it. That if the consultant signed off on it, then it's okay.
Yeah.
And I think what that translates to then in normal practice is that if you're discussing it as a team and making a plan together as a group, it then enables you to possibly take a little bit more risk, but also try different things that you might not have otherwise done if you didn't have the backing of a group. And I think a doctor is still a reasonable enabler of some of those things. And often when some of those potential treatments or potential therapy inputs could influence negatively other stuff, like, for instance, wounds may be at risk of certain things, or certain medications might make you a bit wary of doing some activities. You can basically hopefully navigate a way through that so the patient's able to get the most benefit from their rehab, and hopefully use as many of those new things as possible. So looking back, military career, we made use of exoskeletons in spinal cord injury. We introduced different forms of bracing. We started an osseointegration trial in combination with the NHS. And a lot of those things carried quite a bit of risk, which involved doing a lot of due diligence first, but then offering the opportunity to patients, which the therapists then take on that therapy process. So you're always stronger as a team than you are as individuals. And when I look at the medical legal stuff, most of the times where I'm seeing a block to progress or a pausing of intervention, it's normally because a siloed individual therapist comes across a problem, has to escalate it, sorry, up to other people. That process takes time. Nobody's working together, so nobody really knows what's going on. And you then end up with 2 or 3 months where they get no intervention, slows down all the progress that's been made so far, and then you have to restart when you've sorted out that issue. So if you're able to keep the process going and deal with those issues along the way, all that sort of parallel working, it's always going to make for a better outcome in the end for the patient, as far as I can see.
Well, you've persuaded me. I'll just have to persuade the defendant solicitor now.
Yes, no, absolutely.
Because you do quite a bit of work on a medical legal expert assisting the court with reports, and does that give you valuable insight into kind of the good and the bad of MDTs?
I suppose to a degree. It's funny, when I did different placements, some places I learned brilliant ways to do MDTs, other places less so, and you'd see where it didn't work. And I think the thing that always came across to me was having a room as much as possible of equals, where everybody's got an equal voice. And that came down to as simple a things as, if you've got a team together, just making sure everybody get asked everybody gets asked to give their opinion on a certain topic, irrespective of where they're sitting in the room or how mouthy they are or how quiet they are, but just making sure everyone's got a voice and feels comfortable to raise an issue. I did find that the best MDTs also, you'd have a really good hard discussion. You'd discuss pros and cons. You'd often have very contrary views. But good teams come out, and then basically whatever's decided as the group, that's our decision. So nobody comes out going, well, I really wanted to do this, but we've been told we've got to do that. That never works. And I think the one thing that I greatly benefited from during my time at Headley Court with our team was I had some very strong therapists, very strong therapy opinions at times, but when they came out of the room, they sold the team story as to where we wanted to go and how we wanted to do it. And that for me is the ultimate professionalism, really. You can have your discussions away from the patient, discuss the pros and cons, and then you come out and you hopefully give the patient confidence by showing that uniformity of opinion and approach.
Yeah, yeah, and that's often what people need. They need that confidence in the team. We see it as lawyers, as solicitor and barristers. You're advising the clients. It's a huge event in their life, this catastrophic injury and the claim, and you've got to give them that confidence that you are safe hands. You do know what you're doing, and people will respond well to that.
Yeah, and I think there's a little bit also that selling confidence with honesty as well. So we one of the things I often see in some reports is very black and white statements, and down the line you see how much of an impact that had on the patient. And actually, if somebody, for example, a patient said, I want to run a marathon next year, and at the moment they're still in a wheelchair, then to be blunt, you don't have to say, no, you're never going to run. What you say, you started off with, well, it's a good aspiration to have, but let's see, what do we need to do to get you ready for running? Well, first of all, we need to work on getting you out of the wheelchair. So that's going to be our first focus on our goals. And you can, if people do come out with things that are utterly outrageous, you can be honest and go, well, probably not going to get there, but let's see how well we can go. You don't take it away from anyone, but I think it is important to be confident and honest rather than just confident.
Yeah, yeah. Always play with a straight bat.
Yeah, and you hopefully won't get caught out and end up on the front of the Daily Mail.
Yeah. Well, Rodri, thank you very much for your time, and I've thoroughly enjoyed speaking with you, hearing your experiences and thoughts, and I'm sure those watching this will have benefited from those too. So to our viewers, thank you very much for watching this episode of Stuart's Soundbites, and hope to see you again soon. Thanks very much again, Rodri.
Thank you very much, Warren. Cheers.